Good afternoon, dear colleagues. It's a pleasure for us. Today is a Young Investigator Award, and today we are here with our colleagues from Europe and our colleagues from USA. I would like to present the judges of Young Investigator Award. The first judge is Ajay Gupta from London, Great Britain, MD, PhD, consultant, clinical pharmacology and cardiovascular medicine, BARTS. Director, Foundation Training Program, Royal London Hospital, Senior Clinical Lecturer in Clinical Trials and Cardiovascular Medicine of Cardiovascular Clinical Trials Unit, and Senior Associate Editor, Journal of American Heart Association. Ajay, thank you so much for your connection with us.
Thank you, Irina, and I'm so pleased to be here.
And the next judge is Kristina Sanina from Bronx, New York, USA. She is MD, Division of Cardiology, Montefiore Medical Center, Albert Einstein College of Medicine. Kristina, nice to meet you.
Hi, thank you for having me.
Thank you. And the third judge is Dr. Joe Christian Schneider. He is from Germany, from Assistance Cardiology. And Christian, are you with us? Not yet, as I understand, or?
I'm here. Thank you for the information.
Thank you very much for your connection with us. And I would like to present the specialist from Belgrade, Serbia, Milica Vukevic. She is MD, internal medicine specialist. She is a certified member of European Society of Hypertension and European Society of Cardiologists, member of Serbian Society of Cardiology and Serbian Society on Hypertension. Dear Milica, good afternoon.
Good afternoon, and thank you very much for your invitation.
And dear colleagues, I would like to present my co-chair. It's Zalina Kudzoeva. She is the presenter of НИИ of cardiovascular surgeon at НИИ Backuleva of this center, where the Young Investigator Forum and the Forum of Young Cardiologists proceed. And Zalina, if you want to add something.
Thank you, Irina, very much for this kind of invitation. Dear colleagues from Russia and outside Russia, good afternoon, and happy to be here.
Dear colleagues, if it's not a problem, I think that we can start. And during technical issues, we will start from the first speaker, from Kristina Sanina, because of the time. Kop'eva, I'm sorry, Kristina Kop'eva, because of the time limitations. Kristina Kop'eva will be the first speaker, and the theme of her presentation will be the role of microvascular dysfunction in the pathogenesis of heart failure with preserved ejection fraction. You have 6 minutes.
Good afternoon, everybody. I'm glad to present my report. The prevalence of heart failure in the world is almost 4 million people, and according to multi-center international studies, from 1–2% of the population has heart failure, and the prevalence of heart failure is increasing every year due to different reasons. HFpEF is one of the greatest unmet needs in modern cardiology. HFpEF represents a heterogeneous syndrome with various phenotypes and comorbidities. And recently, an innovative theory was proposed to identify microvascular dysfunction as the common soil of the occurrence of both microvascular angina and HFpEF. And patients with non-obstructive coronary artery disease, despite preserved left ventricle ejection fraction, are more susceptible to hospitalization due to heart failure decompensation. And a new paradigm regarding of microvascular dysfunction is at the center of heart failure development, has been gaining support over the last years. So the objective of our study was to evaluate the relationship coronary microvascular dysfunction with biomarkers of cardiac remodeling, diastolic dysfunction parameters, and the presence of HFpEF in symptomatic patients. We evaluated such biomarkers as soluble ST2, fibroblast growth factor 23, matrix methylchlorinase 9, tissue inhibitor of metalloproteinase 1, and NT-proBNP. Inclusion criteria were non-obstructive lesion of the coronary arteries, documented left ventricle ejection fraction more than 50%, left ventricle diastolic dysfunction or raised left ventricle filling pressure based on echocardiography, and capability of giving signed informed consent. Exclusion criteria were previous myocardial infarction or revascularization in the anamnesis, arterial hypertension and hypertension, different arrhythmias, different concomitant diseases, hepatic or renal insufficiency, and etc. Echocardiography were performed in all patients and with evaluation of left ventricle diastolic dysfunction based on indices according to EAC guidelines. Dynamic SPECT to assess the microvascular dysfunction was performed also in all patients. Adenosine was used as a pharmacology stress agent, and as a result, quantitative indices, stress myocardial blood flow, rest myocardial blood flow were assessed, and the value of coronary flow reserves were calculated as MBF ratio. And we included 59 patients in our study. Impaired CFR was identified as CFR less than 2, and coronary microvascular dysfunction was therefore defined as the presence of impaired coronary flow reserve in the absence of flow-limited coronary artery disease. And distribution of patients was performed by categories of impaired CFR or preserved CFR. Demographic and clinical, baseline demographic and clinical characteristic of the patient as well as echocardiography data did not differ between groups. But in patients with preserved CFR, heart failure was revealed only in 51.4%, when in patients with coronary microvascular dysfunction, heart failure was diagnosed almost in 90%. CFR values correlated with the levels of biomarkers such as NT-proBNP and soluble ST2, and with left atrial volume, E/A ratio, and E/E apostrophe ratio. In patients with coronary microvascular dysfunction, levels of ST2, NT-proBNP, matrix metalloproteinase 9, and TIMP1 were higher than in patients without coronary microvascular dysfunction. Only levels of GDF23 did not differ between groups. Based on ROC analysis, the levels of ST2 more than 1.304 nanogram per milliliter, and NT-proBNP then it's a mistake here, 900.64 picogram per milliliter were identified as the cutoff values for the presence of coronary microvascular dysfunction in patients with non-obstructive coronary artery disease. And when comparing ROC curves, ST2 levels were more significant as the cutoff values for the presence of coronary microvascular dysfunction. So our data suggest that coronary microvascular dysfunction may play an important role in HFpEF. The values of coronary fractional reserve correlated with diastolic dysfunction parameters in impaired CFR was associated with hyperexpression of cardiac biomarkers on fibrosis and remodeling. And serum levels of ST2 were identified as the cutoff values for the presence of coronary microvascular dysfunction in patients with non-obstructive coronary artery disease. Thank you.
Thank you very much. Dear colleagues, do you have any questions?
I have the question. Maybe I have not heard in your presentation. So it was supposed that all the patients did not have any stress-induced ischemia on the result of SPECT, yes?
Yes.
Only just
Yes.
the dysfunction of
Yes,
current
yes.
Okay, thank you. It's very interesting.
Dear colleagues, if you haven't any questions, so we can moving on. Yeah? Okay, thank you very much, Kristina.
And the next presenter will be Kseniya Eruslanova, junior researcher, Moscow, Russia, from Russian Hematologic Scientific Clinical Center, Moscow. Thank you.
Good afternoon, dear professors, dear chairs, and dear colleagues. I would like to introduce you to study of our center, which are about management of older patients with heart failure. First of all, I don't have any potential conflicts of interests, and prevalence of heart failure is rise all over the world. By different study, it can be up to 11% in population. In the population 90 years old and above, it can reach almost 70%. In European study population, it's shown that it's up to 5%, but it's in the study the patients known about this disease. In Russian Epochas CHF trial, it was shown that the prevalence of CHF in Russian Federation is up to 8.5%. It's maybe high because they search for the patients with the chronic heart failure, and that's why it's maybe higher than its average in the Europe. Patients with the heart failure are different, and mostly they are getting older. And they are different between them based on the ejection fraction. If the patients have reduced ejection fraction, it's mostly men with the less comorbidities, with the they are younger and they have less other disease, but they mostly have the coronary artery disease in the past and the acute myocardial infarction. Mildly reduced patients, they're more close to the patients with reduced ejection fractions, and the patients with the preserved or normal ejection fraction, they're mostly older, they're mostly women, they have a lot of comorbidities, and they're very heterogeneous between them. And very often we miss these patients in the evaluation when they look for them, because they're old, they have complaints of the weakness, fatigue, and mostly we can think that it's because of this age rather than some of the diseases. In 2015, we performed a Russian Moscow centenarian study when we looked for the patients who were 95 years old and above, who live in the Moscow. They were community dwelling. Most of them, they were independent. 20% of them, they were more than 100 years old. For 51 of these patients, we get the ECHO. It was used the portable device, and 38 of them didn't have the CHF in the past medical history based on their medical results. When we evaluate these 38 patients, we found that 3 of them have the reduced ejection fraction below 40%. None of them have mildly reduced ejection fraction, and 97 have the ejection fraction 50% and above. When we use the protocols HFA PEF, which were introduced by ESK in 2018, we found that 41% of them have 5 points, so we can diagnose heart failure with preserved ejection fraction. 59 have from 2 to 4 points when we need to perform the additional tests which were above our ability to perform at home for these patients. So we can conclude that based on the NT-proBNP, which were higher than the age level, that most of them have ejection fraction with the preserved ejection fraction. Then we look for the association between echo parameters and geriatric status, and we found that the patients with the diastolic dysfunction and more permanent diastolic dysfunctions more often have dependency, depression, and dementia. And for our knowledge, this is one of the earliest study which look for this. And the big questions in the clinical medicine about the association between what is the heart failure with preserved ejection fractions in the older adults. Is it adaptive or disadaptive mechanism? And since the last year, since October, we started the new project. We're looking for the geriatric patients with the heart failure who were admitted to our center, who are 65 years old and above, who have verified heart failure, who hospitalized in our cardiology department, and who signed the consent to be a part of our study. We performed them geriatric assessment, echo, blood test, and we are going to follow them for 1 year. So far, we enrolled 50 patients, and their mean age is 74 years old. If we look for the patients with the reduced ejection fractions, it's mostly men and then younger than the patients with the preserved ejection fraction, who are predominantly women. We also look for the geriatric status. We found that they're quite fit and well. It's less people who are frail, but we have patients with the prevalence of the depression. We have patients who are dependent and who have the cognitive and nutritional status decline. And when we work with our patients with the heart failure, especially with the older one, we understand that it's not only gold treatment is only one way to treat these patients, because we cannot ignore their comorbidities, we cannot ignore their frailty status, their depression, their social and financial resources, because some medications are quite expensive when we speak about the patients with reduced ejection fraction, especially with the new medications such as SGLT2 inhibitors or sarcopidil valsartan medications. We can look for the cognitive impairment, because the patients very often with the heart failure have cognitive impairment and they have atrial fibrillation, they need anticoagulation therapy. And we are continuing to our study to get the more results and to find the appropriate way to manage these patients, because we try to make a friendship between cardiology and geriatricians. It's impossible to be everywhere, but we can help each other to improve the quality of life and life expectancy for all the patients as well. Thank you very much for your attention.
Thank you, Kseniya. And do our judges have any questions?
I have one question. A very good, clear presentation, and it's an interesting cohort. Can you explain why there's an age difference there? Is this a survival bias because of patients with reduced ejection fractions are less likely to grow older than 75? Like for your centenarian study, which 95-year-olds, majority of them were having a reserved ejection fraction. So is there a bias there?
It's maybe a bias here, and maybe the patients with the really reduced ejection fraction, they have limited life expectancy. Mostly the new medications which has really improved life expectancy appeared in 90s. And these patients were in 2015, 95, 100 years old. So if they have MI earlier at 60, 70, most probably they will not survive to this age with the low ejection fraction. And the patients all over the world, they're getting older, and the predominantly patients with the old age, they have reserve ejection fraction. And on American Association this year, there was a big symposium with the geriatricians who told that they sometimes even internal medicine doctor, family medicine doctor, they don't send these patients to cardiologists because the complaints are very broad. So this is a problem with the preserved ejection fraction, and maybe it's also the problem which I shown the results of the EPOCHA study and European study. If the patient know about the heart failure, it's around 5%. If we started to screen directly, it's rose up to 11%. So maybe we need to look more carefully for these patients.
Jay, are you satisfied about the answer?
Yeah, I'm okay. Thank you.
Thank you.
Thank you so much. And also I have one question. Kseniya, could you tell us, please, what is your impact in this work?
Impact, my most impact was for the centenarian study. It was my PhD work, and now I'm like look after the study with our cardiology CHF study in our center.
Thank you so much.
Thank you.
Thank you so much. And I would like to present the next speaker. He's Ognerubov Dmitriy, and the theme of the speech will be about the analysis of radial artery occlusion, causes and methods of its prevention after interventions using radial access. Results of the a priori study. Dmitry, you have 6 minutes.
Hi there, how's it going? Everything good, I suppose. Yeah. So yeah, my English is pretty not so well as the previous speakers, but I hope that my laptop can be pretty helpful for me. So anyway, let's go talking about the study. So I don't have any potential conflicts of interest, and you know, I'm very thankful for the opportunity. I'm very thankful to Irina because she invited me here. So that's why I'm here today. Anyway, yeah, thank you so much. So let's gonna be closer to the study. So the background, what is the background? Everybody knows that radial access gonna get, you know, much more common for different procedure, for coronary angiography, for PCR, and everybody knows that it's gonna be like, you know, gold standard. So, but you know, we have the, you know, well, the strong situation with the radial excess and the weak. The weak part is probably because of radial artery occlusion, which get after their coronary angiography and PCR. So the main idea of this study is to find the predictors of radial artery occlusion and to find some, methods which could help us to reduce this complication. So what about the objective? Well, we have the two part of this trial, the prospective part and retrospective. So if we talk about retrospective part, it's just, about the real world, because a lot of studies said that, the radial artery occlusion is only, 40% or, 4% or 10% at least. But, well, we find that real world is quite different. And I will show it in the end of the presentation. So the perspective part is about 100 patients, which were divided into two groups, and of course we were randomized to get short-term hemostasis and their prolonged hemostasis. So you can see it quite well in this slide. So what about the prospective part? You can find that if we find the radial artery occlusion after the hemostasis, we have to, we did an hour ipsilateral compression. What is it for? I mean, well, this is a that easy technique which help us. I hope it helped for everybody to rescue the radial artery occlusion. And the enrollment criteria is on a slide. Just, we exclude the patient with acute coronary syndrome and coagulopathy due to, aggressive anticoagulant treatment. So that's why we exclude them. The baseline characteristics are shown in this slide, and you can see that there were no difference between two groups of prolonged and short hemostasis group, and their per-procedural characteristics were also quite similar. So, but except of duration of hemostasis, of course, because that's the main part of the study, Yeah. So what about the radial artery occlusion after hemostasis? Yeah. Well, in prolonged hemostasis. Oh, sorry. That's of course it have to be reversed. The short hemostasis is in this group. Radial artery occlusion was 3.2%. So this is that easy technique to rescue your radial artery occlusion after the hemostasis. You have to just push the ulnar artery for an hour. Usually you have to use a Terumo band, for example. I mean, if you have a different device, you can do it. So yeah, and after 1 hour, we found that some radial occlusions were rescued, sorry. And their radial artery occlusion after recanalization in prolonged group was similar. You know why? Because, you apply this technique after 10 hours, you found nothing. So the main idea is to apply this technique just after 3 hours. So when the thrombus is, the smooth, not so stiff. So that's why the radial artery occlusion rate were quite different between three groups. Of course, the big, in retrospective part, in real world, RAO rate is quite high. I mean, 21.8%. Yeah, the lack of time. Yeah, I've seen it. Thank you so much. So long story short, let's go to talk about the conclusion. The incident you have already seen it, the incidence of RAW was 1.4% compared with 10.1% with the traditional methods, and that's all. That's enough. With my study,
you should.
Just a small talk. Yeah, prolonged hemostasis, female gender, type 2 diabetes mellitus, smoking, and the radio artery to introduce R factor associated with radial artery occlusion, and the rescue radial artery recanalization was effective in 30%, but only in a short hemostasis group. That's the end, probably. Yeah, that's the end. Thank you so much for having me here today, and don't hesitate to ask your questions.
Thank you so much, Dmitry. Dear colleagues, do you have any question, please? Dmitry, could you tell us, please, it's your PhD work or it's the prolonged one of?
Yeah, well, yeah. It was.
And what is the
PhD
future of this work, or you concluded it all?
That's a great question. Thank you so much for this. Because, well, I'm trying to produce my special device, which help us to compress ulnar and radial artery at the same time. So that is the key point of the study. You have to close ulnar artery just to make sure if radial artery is still open. So yeah. Well, I hope that after 6 months, my device gonna be I can produce it and register with a legitimation. I don't know. I mean, register in Russia, so in Eurasian Union as well.
I have a question.
Yeah, please.
For your talk, and I just want to summarize. So basically, you had a TR band on the patients, right? And then you diagnosed the occlusion of the radial artery after 2 hours. What was it?
Yeah, right. After 3 hours, actually. Yeah.
After 3 hours. Okay.
Yeah.
And then you just turn around the.
Yeah, kind of. Well. Yeah, that's a good question. Actually, we use just a bandage for the hemostasis. No, not Terumo band. So we use just bandage to compress the radial artery. But after that, yeah, if I found radial artery occlusion, so I use TR band, or as well I could use you could use just a bandage. It doesn't matter, actually. You have to push the ulnar artery with a different device. It doesn't matter if it's gonna be Terumo band or Finale or Syndistal. I mean, it doesn't matter, actually.
And do the patient and this ulnar compression is for how long?
Oh, just an hour. Yeah, just an hour. Yeah, that's enough, actually. I used to, I tried to use, more than 1 hour, but it didn't do any difference.
Don't the patient develop numbness? Now you have both arteries occluded.
Yeah, that's a great question as well. So yeah, some patient had, just 10%, just a numbness for, a day. And after that, they felt nothing.
Okay, thank you so much.
Yeah, thank you for your interest.
Thank you, Kristina. I was just going to ask you to comment because you are in this field of cardiology in New York.
Oh,
so
sorry.
Thank you. No, I was just commenting to Kristina. Thank you, Kristina.
Thank you, Kristina.
Yeah.
Can I just add an additional question to Kristina's, because that's what I wanted to ask also. But in addition to the numbness, have you noticed any signs of ischemia, and because of the occlusion suddenly getting the flow, is there any risk of embolization?
Yeah, that's a great question. Yeah. Well, actually, the study found that there were no special symptoms for radial artery occlusion, and the patient, radial artery occlusion was well tolerated by the patient anytime. I mean, not in this study, but in real world as well. So they they could feel just a numbness or some feeling in their index and pollicis, but they were rescued from these symptoms after from 3 to 6 days. So yeah, and again, thank you for this question. And some patients said that, oh, there were no pools here, and I said, oh, that's my fault. Sorry so much. Anyway, I mean, of course, it is not a problem for the patient. Just in case if he is, pianist, only for these patients, probably it's a big deal.
Thank you very much.
Yeah, sorry.
Dear colleagues, we haven't time. Unfortunately, we have a limit of time. And the next?
And the next presenter is Maria Simonenko from St. Petersburg, and the theme of the presentation: management of new coronavirus infection patients and heart transplant recipients. Please go ahead. Thank you.
Thank you. I have no disclosures. So infectious complications after I'm sorry. Okay. So infectious complications after transplantation are one of the leading causes of morbidity and mortality, and it was even before the pandemic. So COVID-19 became a challenge for people all around the world, but especially for patients who are immunocompromised. In 2010, our heart transplant program was initiated, and almost 200 recipients were heart transplanted. All patients were managed with triple drug immunosuppression, plus, and most of them, we used induction. Infectious disease prophylaxis we prescribed only during the first year. So all our patients before the discharge from the hospital were included in dispensary observation group, and we follow up them for the whole of post-transplant period, and our recipients live from all over Russia. After 2 years of pandemic, we had 120 cases of COVID-19 infection in 8 recipients. So 1/3 of our recipients had COVID-19 about 2 or 3 times. We continue to keep in touch with our patients all the time after heart transplantation, and it wasn't difficult for us to switch to most of our remote consultations and to manage them wherever they're living. And we started our treatment from the onset of clinical symptoms, so literally from the first day when they called us. So this included temporary reduction of immunosuppression for about 14 days, and also I managed that with isotonivirine, and I understand this can raise some questions, mucolytics, antibacterial agents, vitamins, and anticoagulants. In case of deterioration, or if there was no effect of the treatment, we needed the initiation of steroids. And only 10% of our patients required ventilator support, non-invasive. None of our recipients had invasive ventilator support after 2 years of COVID-19. Most of our patients were managed while they were at home, and only a small number of recipients we needed to admit to the hospital because of the COVID-19 or other reasons. Only 40% of our patients had a moderate course of the disease. Pneumonia developed in most of our recipients, and also we faced acute rejection with transplant dysfunction, acute stroke, and other cardiovascular complications in our recipients. But only 2% of our patients died from COVID-19 associated conditions in more than 3 weeks from the onset of clinical symptoms. And right now, we vaccinated most of our recipients, and 1 year ago, the HLT guidelines included Sputnik V as a vaccination to heart and lung transplant recipients. And now more than 90% of patients following all over the Russia had immunization against COVID-19. So our study showed high degree of infection with COVID-19 in patients after heart transplantation. 1 in 10 recipients may develop COVID-19, and even few times. The possibility of remote consultations, compliance, patients, adherence, and the initiation of treatment from the first day of clinical symptoms, this helped to increase the survival of our recipients. And after 2 years from the start of pandemic, our mortality is really low, about 2%. And vaccination against COVID-19 is effective and will reduce the risk of COVID-19 infection in these patients. And so this is our patients who were heart transplanted and continue to play football with their doctors and skiing and perform on the world championship. Thank you.
Thank you, Maria. Very interesting presentation and this very actual on this high-risk group of patients. Dear colleagues, do you have any questions?
I have just a comment and a question. You said that there was a vaccine. Obviously, we all know that vaccine will protect these kind of patients, but I didn't see any data in your cohort whether there was a differences in the presentations and a risk after vaccination or before vaccination.
Because of vaccination, because all of our recipients managed with triple drug immunosuppression or with 2 drugs and long-term follow-up, they don't have any symptoms after the vaccination. Whatever we are talking about, vaccination against flu or pneumococcus or something, and this help. Of course, patients can develop COVID-19 after the vaccination, but I have around 24 patients who developed it. But when we can compare those who weren't vaccinated, even having the really high level of immunoglobulin G, there was a really big difference. So my vaccinated patients didn't have any changes on CT. Their CRP was normal, while the others were really unwell, and some of them needed to admit to the hospital. So I really see the difference for 6 months in the beginning when we started the vaccination. So the guidelines were published from HLT in April 2021. For 6 months, there was nothing. All vaccinated patients, no COVID-19, nothing. They were really well, no adverse effects. And only since November, we started to face some kind of the mild course of the disease. They could watch TV at home, no symptoms, nothing. But yeah, they can develop.
Thank you. I think, yeah. My only suggestion is when you're going to write this paper, probably you need to provide that data so that it becomes a more robust paper.
Thank you so much. Maria, I also have one question. You made an accent on remote monitoring of this patient, and what kind of monitoring do you use? It was telephone calls, or you have some app or some system to monitor this patient in remote condition?
This is the system that we have all over the world. All transplant doctors need to continue to keep in touch with their recipients, and all patients have their phone number of the registrar or something. Every hospital has their system. But our patients, of course, have my phone number, and they call me whatever is going on. And we have 7-hour difference with some of my patients. So my patients right now live from Moldova to Vladivostok. This is a really big difference. And they call me like 4 a.m. in the morning that they're going to get unwell. And in this case, we use, of course, phones. Also, we can use telemedicine in case if they were admitted to other hospitals. So there are not a lot of transplant doctors in Russia, and even patients were admitted to other hospitals, we need to continue to follow up them and work with other doctors also.
And also I would like to ask Melissa Lukevich, because she's in this theme in her country, and also she's studying in Vienna on this sphere. What can you say about this theme, and what can you add about it?
Well, actually, thank you for your question, because I wanted also to give a comment I was very lucky to be 3 months in Vienna in AKH with Professor Andreas Zuckerman. He's actually president of International Society for Heart and Lung Transplant. And actually, we should first of all follow the guidelines. In some countries, like in mine, people are sometimes afraid of suggesting of vaccination in heart transplanted patients. Definitely, we should follow the guidelines, because for those kind of patients, it's even worse if they are not vaccinated and get COVID and get some other superinfection, bacterial superinfection, or some other complications after COVID. So it's a much better perspective of these patients after vaccination. Also, they are checking the effects of a vaccine in this kind of patients, and I think this network between countries and communication between doctors and patients, which is even much closer in this field of cardiology, is very important. And we should just keep together in all this, because especially in this time of pandemic that is still ongoing, it's very important to keep really close to our patients and to give them the right suggestions about vaccination. So the good thing in relation between doctors in this field and patients is that close communication that we have. Sometimes it's 4 a.m. in the morning, but usually it's much better to have the information in the right moment, so we can predict any kind of complications and stop them on time. So thank you. This lecture was really great. Thank you very much.
Thank you. Thank you very much, Melissa. Thank you. We are going to the next presentation, and the next presentation is Elena Serezhnina from St. Petersburg, and the theme is the applicability of the Valsalva maneuver and speckle tracking echocardiography in the diagnostic of heart failure with preserved and mildly reduced ejection fraction. Thank you.
Thank you very much. Good afternoon, dear colleagues. As my colleagues already mentioned, heart failure is a common pathology and it's affected more than 64 million people all over the world, and its prevalence is steadily increasing over the time, and the major part of these patients are patients with heart failure and with preserved ejection fraction. However, despite the necessity of the timely diagnosis of this pathology, American and European cardio communities haven't not already proposed a single algorithm and criteria, a set of diagnostic criteria for detecting heart failure with preserved and mildly reduced ejection fraction. In Europe, above, it's necessary to improve algorithm of screening and methods for diagnosing this pathology. So the technical improvement of ultrasound diagnostics permits us to visualize each region of the myocardium like a specific, relatively stable and unique bottom structure, and it changes during the cardiac cycle. So STE measures the characteristics that can quantify the local and the regional, the systolic and diastolic myocardial function in 3D with the following parameters: it's myocardial information or longitudinal strain as well, left ventricular movement models like you see on the graphics, and also the dystrophy of the myocardial fibers that are also presented on this slide. During this test, during Valsalva maneuver, there was a consistent increase and then decrease of preload on the myocardium, as well as an increase of the postload of the left ventricular myocardium, which provokes a manifestation of the systolic and diastolic myocardial dysfunction that can't be seen during still. My work is a clinical monocenter perspective study that solves the problem of the development and determine the diagnostic significance of this new technique for assessing the deformational parameters of the left ventricular myocardium based on STE and carried out with functional tests. So you can see on the slide also the criteria of exclusion and also inclusion criteria and the baseline of the patients. We took 202 patients. The results of the work demonstrate a significant and gradual, as you can see by the table, decrease of an ejection fraction and left ventricular global longitudinal strain parameters during the Valsalva maneuver. If we are comparing patients with preserved, mildly reduced, and control group of patients. At the same time, the general and segmental and informational parameters of the left ventricular myocardium with a greater accent are impaired in patients with heart failure with mildly reduced than patients with preserved ejection fraction. And this data indicates a progressive and more significant decrease the fraction and the longitudinal strain, if we can see on this slide. So on the left-hand side, you can see the steel, and on the right-hand side, you can see the STE during the Valsalva maneuver, and you can see how developed and how different the longitudinal strain, like local, then also a global longitudinal strain in different groups of patients, and we can see the progress of systolic dysfunction. Also in patients with heart failure preserved ejection fraction, there was a gradual and mildly reduced, of course, there was a gradual increase in end-systolic and diastolic volume at rest compared with the control group. So we can say about the diastolic dysfunction. And there was a gradual decrease of ejection fraction and GLS, so global longitudinal strain, in heart failure patients and heart failure mildly reduced ejection fraction patients groups compared with control during the Valsalva maneuver. And also in all groups, there was a more significant relationship between ejection fraction and global longitudinal strain during the Valsalva maneuver than at rest. So this fact confirms the informative of our method, and also the participation of a systolic component in the genesis of heart failure with preserved and mildly reduced ejection fraction. Previously, it was only proved the diastolic component, and so we determined by indicators of global longitudinal strain that it could be really informative value and impact. Thank you very much for your attention.
Dear colleagues, any questions? Elena, I would ask you the question about your impact in this work.
So this is a part of my PhD work. So I made a design of this study. Also, I made by myself all the protocols, echocardiography, because I have got a certificate. So I made a simple echo and STE managements, and also I made all the statistics.
Thank you, Elena. Could you just comment, how do you think, what is the future of this method in real clinical practice?
I think it's, thank you very much for the question. I think it's it could be very useful when we are talking about the initiation of the therapy for these patients, and also about the prophylactics. So we are trying to maybe to evaluate the risk of the patient to then the risk of the heart failure developing in the patients.
Thank you. Any other questions?
Just Elena asked a query and a clarification, if you can give. I thought these findings which you found, and they are interesting work and a very large body of work, so you must be commended about that. But is these findings any surprising at all? They were expected, isn't it?
It was, thank you very much for a question. I don't think it was unexpected, because previously scientists and cardiologists talked only about the diastolic dysfunction, and we made a reveal that there is also a systolic component in the patients and a pathology of heart failure with preserved ejection fraction.
Thank you.
Thank you very much. Dear colleagues, if we haven't any questions, so we will moving on. Thank you very much, Elena. And I'm glad to present the next speaker, Dvadtsatov Ivan. The theme of the work is application of semi-rigid ring, neo-ring, for correction of mitral valve insufficiency. You can start. You have 6 minutes.
Good afternoon. Sorry. Good afternoon, dear colleagues. Given the level my English, I will use this little support devices like previous speaker. Let's start. I'm going to present a report of application of semi-rigid ring neo-ring for correction mitral valve insufficiency. Global epidemiologic study estimated that there were 35,700 deaths from degenerative mitral valve diseases worldwide in 2017. Increased life expectancy and the overall population growth have resulted in 112% increase in deaths related to no rheumatic heart valve disease since 1990. Over the years, the prevalence of degenerative mitral valve malformation over rheumatic ones increases. Surgical treatment significantly improves the survival prognosis for these patients. With degenerative and secondary forms of valve insufficiency, the probability of preserving the valve is as high as 90 to 100%. Up to date, several well-proven technologies of mitral valve reconstruction have been developed: French correction, respect rather than reject, and American correction. Today, there are more than, Today, there are more than 40 different types of annuloplasty devices in the cardiac surgeon's arsenal, different in such key characteristics as stiffness, shape, manufacturing materials. A common unifying feature of most models is the use of synthetic materials as a cuff. Up to date, there have been about 60 clinical studies and comparing different types of devices and about 30 experimental animal studies, but there is still no answer to which devices is perfect. The scientists of Research Institute of Complex Problem, together with the specialist NIACOR, developed a new biological ring for mitroplasty neo-ring. The framework is made of radiopaque nitinol with shape memory covered with xenopericardium, stabilized epoxy compound with antithrombotic coating. We evaluated multi-helical computed tomography with ACG synchronization in 10 patients who underwent mitral valve reconstruction and annuloplasty with a new ring. We also compared them with patients who underwent semi-rigid memory-free ring and rigid mid-inch ring implantation. This slide shows the study data and demonstrates preservation of anteroposterior diameter dynamics. Anteroposterior diameter dynamics after implantation of the neo-ring. The average value of the segmental movement of the neo-ring from diastole to systole was approximately 5.7%. That corresponds to physiological dynamics in native mitral valve according to literature data, and preservation of non-planar mitral valve in comparison with other rings. We evaluated the clinical effectiveness of the neo-ring in comparison with the rigid ring mid-inch. In this prospective randomized study, include 62 patients with degenerative mitral valve disease who were scheduled for isolate mitral valve repair in our institute from September 2019 to April 2021. The clinical characteristics of the patient are shown in table. There were no statistically significant difference in baseline parameters among the groups. There were also no difference between the groups at baseline echocardiographic data. After revision of the mitral valve leaflets and subvalve units, the following reconstruction techniques were used: chordal prothesis, second-order chordal translocation, resurrection techniques, triangular and quadrangular, and combination of these techniques. In all cases, mitral valve plasty was complete by implantation of neo-ring or a rigid ring. Aortic occlusion time and cardiopulmonary bypass time did not differ between the groups. This slide presents echocardiographic data at the time of discharge. Lower values of transvalvular diastolic gradient were observed in the neo-ring group. By the moment of discharge from the clinic, all patient had significantly decreased circulatory insufficiency and increased tolerance to physical activity. All patients were classified as class 1 heart failure according to New York Heart Association after the intervention. Implantation of semi-rigid ring, neo-ring, has a positive effect on reverse cardiac remodeling in the long-term follow-up period compared to rigid rings. This slide shows valve-related complication with no statistically significant difference between the groups. Survival and freedom from mitral regurgitation above the second degree in the groups were comparable. In conclusion, the use of new biological neo-ring and correction of displaced mitral valve insufficiency has shown its safety and efficacy in comparison with the valve-proven device. And also annuloplasty with neo-ring preserves physiological non-planarity of mitral valve with preservation of the anteroposterior diameter dynamics. Thank you for your attention.
Thank you, Ivan. Do we have any questions from our colleagues?
Yeah, I do have several questions. Thank you so much for presentation. I maybe miss it. What was the percentage of the primary MR versus like secondary MR and both in this patient?
Primary mitral insufficiency or second mitral insufficiency? All patients had primary mitral insufficiency with dysplastic mitral insufficiency.
Okay, and what was the like end diastolic diameter of this patient? Was it?
КДО левого желудочка.
Can you repeat, please, your questions?
And diastolic diameter.
After intervention or before intervention? Before?
Yeah.
Can I present table before intervention?
Is it possible to use a slide, please? Can you show the slide?
Echo characteristics.
I mean, in many cases, you differentiate the severe MR and chronic by the end diastolic diameter, which gets increased. And you're talking about the remodeling of the ventricle. So how do you measure it?
Ремоделирование, как вы оценивали, за счет каких параметров?
CRA, DAC, KDO, left ventricular, left atrium diameter, right atrium diameter, all echocardiographic data we evaluated.
And we can see on this slide there is you can see the end diastolic volume was increased in two groups of patients.
So, dear colleagues, do you have more questions? Maybe the colleagues from here have some questions. No? Ivan, thank you very much. And also, I would like to ask one question. We're talking about neo-ring. It's like a new one of the ring for mitral insufficiency. But can you explain us, maybe you will give us 3 points of privilege of this ring if we compare it with another rings? 3 pluses of quality or function of this ring.
Neo-ring is semi-rigid ring. Neo-ring is a biological ring. If we can this ring for infection endocarditis and it's a best ring.
And it's more than 3. Thank you so much. If we haven't any more questions, so we will move on. Thank you, Ivan. And the next speaker will be Murzakova Aigul. She is from Kazan. And the theme of the work is the markers of poor prognosis in patients with chronic heart failure with preserved left ventricular ejection fraction genetic aspects. Please.
Good day, dear committee, colleagues. Today I want to present you our work, Markers of Poor Prognosis in Patients with Chronic Heart Failure with Preserved Left Ventricular Ejection Fraction genetic aspects. The aim of the despite major advances in the treatment of congestive heart failure, sizable number of patients suffer from significant morbidity and mortality. And this group of patients also demonstrate devastating 5-year mortality rate approaching to 75%. The aim of the conducted research is to reveal specific markers of 5-year outcomes in CHF patients with preserved ejection fraction based on ZBTB70 gen polymorphism. So, a cohort of 70 patients affected with established CHF. All of them were older than 18 years, both sex with all functional classes according to a New York Heart Association and symptom ejection fraction more than 50%. All the patients underwent a detailed clinical assessment, including careful review of medical history, comprehensive physical examination, standard 12-lead electrocardiogram, echocardiography, and some laboratory tests with genetic analysis using the PCR in real time to amplify ZBTB70 polymorphism. And after prognosis evaluation, patients were divided into 2 groups. Composite endpoint included death and non-fatal myocardial infections and stroke, and patients with favorable prognosis. What is a clinical portrait of our cohort? The most common etiology was coronary artery disease in combination with hypertension. The 3rd and the 4th functional classes were presented in a majority of patients. Also, patients with comorbid factors such as diabetes mellitus, atrial fibrillation, chronic kidney and pulmonary diseases. Then we divided our group into 3 based on genotype and analyzed a clinical portrait of ZBTB70 gens carriers. The comorbid condition rate are different in each group, as we can see. So, due to our research, we find out that 61% achieve composite endpoint. Most of the deaths are cardiovascular in nature, with 52% resulting from heart failure decompensation. Comprehensive analysis revealed the presence of each of these factors predicts higher risk of poor prognosis, increased heart rate, left atrium size, level of HDL and total protein. Next point, genotype distribution. Differences in composite endpoint structure between genotypes are well recognized, and achievement of the composite endpoint was more common in patients with CT genotype, non-fatal infection, and stroke were more common in patients with CC genotype. And predictors of poor prognosis in patients with CC genotype include creatinine level, CT genotype increased blood pressure in pulmonary artery, and TT genotype is hyperglycemia. There we can see her clinical characteristic, etiology, comorbidities, functional classes in 2 groups, and we can say that they were relatable at all. Summarizing, despite heterogeneity of results, every group of patients demonstrated specific conditions associated with prognosis, and these markers may be suggested as an appropriate criteria to identify individuals with high mortality risk. In this way, the more precisely define the mechanism of any diagnosis, the more precisely the physician will be able to predict and modify the relevant outcomes. Thanks for your attention.
Dear colleagues, I would like to ask the first question. Aigul, could you say us, please, what the novelty of this work? It was novelty. What new things this work can give in our cardiologist soul society?
I understand that all of these parameters are very have very high impact on the chronic heart failure. And especially in these genetic aspects, we can divide groups of patients with high risk. And it helps us to make new steps to personalized medicine with all aspects and to modify the relevant outcomes at all.
Thank you so much. Dear colleagues, maybe you have any questions? Okay, so Zalin.
Thank you. The next, thank you.
Oh, okay, thank you.
Thank you. And we're going to next presenter. And the next presenter is Shaleva Veronika from Kemerovo with the presentation on the features of early rehabilitation with aerobic exercises in patients after surgical corrections of valvular heart disease.
Good afternoon, dear colleagues and chairs of Young Investigator Award. I am grateful to present the results of our scientific work on Young Cardiologists Forum. Each country has its own concept. I'm sorry. Each country has its own concept of initiation, duration, and intensity of exercise training during rehabilitation program after valvular heart disease correction. Cardiorehabilitation is not so widely spread in our country. There are a lot of limitations to perform complex rehabilitation after open heart surgery. However, in guidelines, there is no single concept of postoperative rehabilitation after heart valve surgery. The current situation about rehabilitation of patients after valve surgery is based only on the guidelines after coronary artery bypass grafting. Though the program after CABG should not be applied blindly to patients after valvular heart disease correction due to differences in hemodynamics, comorbidity, and functional status. Therefore, the principal aim of our research was to evaluate the effect of the developed program of early rehabilitation with physical aerobic training on the treadmill in patients after surgical correction of valvular heart disease. The main inclusion criteria was the planned valvular heart disease surgery with bypass non-infective genesis. Other inclusion and exclusion criteria you can see on the slide. The study included 80 patients with valvular heart disease who underwent cardiac surgery for the valvular disease correction in bypass conditions. Patients in the control group, as you can see, underwent standard cardiorehabilitation after the surgery, which includes physiotherapy exercises and those working from the second day after the surgery. In main group, in addition to standard cardiorehabilitation, on the 8th day after the intervention, the physical training on a treadmill was initiated with a personalized selection of a training program based on the results of cardiopulmonary tests. The duration of the training was 14 days. On the 7th day after the surgery, at the end of the training course, the dynamics of the cardiopulmonary test, echo parameters, quality of life, SF36, and the level of anxiety and depression, according to the hospital hearts, were assessed. The personalized early rehabilitation program was based on the value of peak oxygen consumption, and then, according to this formula, the speed of treadmill was adjusted. The exercise training had 3 steps: preparatory, main, and final, and every stage lasted for 5 minutes. You are welcome to see it on the slide. On the 7th day after surgery, the control group and the main groups were comparable in functional and hemodynamic status, quality of life, and anxiety depression levels. After 14 days of training, according to the cardiopulmonary test, in the main group, there were significant increase in physical tolerance, a significant increase in peak oxygen consumption. The dynamics of physical tolerance in the control group was not so impressive.
Additionally, we found significant decrease in number of patients with subclinical anxiety depression scales in the main group, with more pronounced positive dynamics than in the control group. According to the results of our research, the physical training on treadmill did not influence on the deterioration in hemodynamic. During physical training, there was no change in rhythm. Episodes of ischemia, life-threatening cardiac arrhythmias, desaturation. The main reason for stopping the training was weakness and fatigue of the patients. So they developed 2-week early rehabilitation program with physical aerobic training on the treadmill in patients after surgical correction of valvular heart disease. May be applicable for the patients, but needs further study. Thank you for attention.
Thank you very much, dear colleagues. Our dear colleagues, do we have any questions?
Yes, I do have a question. What was the percentage of mitral valve and I guess tricuspid also in these patients?
Am I right? How many patients were with mitral pathology? Repair. 34 patients with isolated mitral valve surgery. 34 patients isolated, and other patients were with combined pathology, stenosis of our aortic stenosis and недостаточность.
Kristina Sanina asked you about how much patients were only with mitral lesion and how many patients were with mitral and tricuspid lesions.
In all, there were 20 patients with mitral valve correction and 24 patients with mitral and tricuspid valve correction.
Mm-hmm. And do you start the rehabilitation like how many days after the surgery?
After 8th day in main group, we started the early rehabilitation program, which was made personalized according to the cardiopulmonary test.
Okay. And is any group of this like valve division did better, or you don't analyze these subgroups?
It's not. It's difficult to. It's difficult to get and analyze these results на данный момент on this time, but maybe at the end of the research, we in the future we maybe work on it. Будем работать.
I think it's very important for your work because each valve pathology actually remodels the heart differently.
Of course, yes.
Tolerance is different in patients with this. We compare aortic and mitral.
Of course, but there are no research and there are no cardiac rehabilitation for valve surgery. So it's the first step to analyze this situation and rehabilitation for these patients. It's only the beginning.
It's a good work. Thank you so much.
Thank you.
Thank you. Any other questions from our colleagues? I just wanted to comment and to Kristina mentioned, and I also wanted to comment that this is really a very actual work because by the word on one of the last scientific board meetings here in our center, our director of the center, academician Elena Zelkovna, also paid a great attention to the role of early rehabilitation of this group of patients after valve surgery, especially in the group of mitral valve surgery patients. So thank you. Kristina, thank you.
Thank you for your questions.
So we are going to the next speaker. Yeah, and the next speaker is Khugaeva Eleonora. She's from Moscow, and the theme of the work is the association between long-term perioperative atorvastatin or rosuvastatin intake and acute kidney injury in adults patients undergoing heart surgery, a propensity score matching analysis. Eleonora, you're welcome.
Good afternoon, dear colleagues. I want to present to you our scientific research on the topic association between long-term preparative atorvastatin or rosuvastatin intake and acute kidney injury in adult patient undergoing heart surgery. Acute kidney injury is among the expected complications of the cardiac surgery associated with an increase in the incidence of subsequent progressive chronic kidney disease, as well as with high mortality, increase in the length of patient stay duration in the hospital and the economic cost of patient treatment. The mechanisms underlying AKI are multifactorial and are not yet fully understood. These include inflammation, oxidative stress, hyperperfusion, ischemic reperfusion injury, and renal troubles, and etc. Prevention of AKI is an important component of treating this patient category. Cheng et al. Noted an increased risk of postoperative AKI in a patient receiving rosuvastatin. Based on the result of meta-analysis involving the cohort study, a reduction on the AKI incidence was established in the setting group compared with the control group. On the contrary, in meta-analysis of randomized clinical trial, statin therapy was noted to increase the likelihood of postoperative AKI. The ESCTS guidelines on perioperative medication in adult cardiac surgery do not recommend to initiate statin therapy shortly before cardiac surgery, class 3rd level A. They also emphasize that no data are available on whether patients already taking statin should continue or discontinue therapy preoperatively, although in common practice statins are continued preoperatively. Accordingly, the results of studies on the effectiveness of statins are varied and require further study. The objective of our study was to compare the effect of long-term preoperative intake of atorvastatin and rosuvastatin on the incidence of AKI in the early postoperative period after CABG surgery. We conducted a retrospective cohort study. The data were collected from the general electronic database of the MedWork clinic. The research includes an analysis of the hospital stay in patient who underwent CABG from 2016 to 2020. Overall, 1,971 CABG operations were performed. The incidence of AKI was associated on day 2 and day 4 after the surgery. The inclusion criteria were as follows. This performed CABG surgery is related or in a combination with other interventions. The patient's age over 18 years old, long-term preoperative intake of atorvastatin or rosuvastatin, and continued use of the same statin during the hospital stay. The exclusion criteria was CKD stages 4 and 5 patients, some other statin intake, replacement of the statin for another before surgery or during the hospital stay, the presence of concomitant sensor. The data collection was carried out using clinical and analytic data, laboratory and instrumental studies, transthoracic echocardiography, electrocardiography, Holter EKG monitoring, intraoperative intensive care unit. The primary clinical endpoint was the development of AKI. The presence of AKI was identified sense of the KDIGO criteria. propensity score matching was performed to compare the findings in our study groups. A total of 958 patients were matched in a 1-to-1 ratio based on propensity score. And were calculated for each patient using multivariate logistic regression based on the following covariates: age, gender, weight, diabetes, hypertension, number of distal anastomosis, medicaments, therapy, both at baseline and in the early postoperative period, and using calipers of with equal to 0.001 of the standard deviation of the propensity score logit. The characteristic of the entire group and the propensity matched population are shown in table. Of the enrolled 958 patients, the analysis includes 164 patients taking atorvastatin, 296 patients taking rosuvastatin, and 498 were not exposed to long-term preparative statins. After one-to-one individual matching based on propensity score, pairs were generated. As you can see, the key incidence values did not differ significantly between rosuvastatin, atorvastatin, and control groups, both on postoperative day 2 and 4.
You can go to conclude.
Там можно следующий slide. And the next slide, please. And this study, we conducted a comparative analysis of the effect of long-term preparative intake of atorvastatin and rosuvastatin on the development of a key in the early postoperative period after CBG. Our findings revealed that long-term use of either of the two statins did not increase the incidence of postoperative key after CBG compared with the control group. Besides, we found no difference in the key incidence between atorvastatin and rosuvastatin groups. Thank you for your attention.
Thank you, Eleonora. Do we have any questions from our board? No. Thank you. I have a question. Can you just tell us shortly, what was the primary hypothesis of your study, and did you receive the results of the study according to your hypothesis?
Yes, of course. We assumed that we wouldn't receive receive data on acute kidney injury and long-term use statins and prove it. Will you prove it?
I'm so sorry. Thank you. Eleonora, I would like to ask the next question. Rosuvastatin and atorvastatin, are there statins which have elimination with by the kidney?
Sorry, elimination.
Выведение, метаболизм, синтез, да? Не синтез, метаболизируются они. Розовостатин и аторвастатин метаболизируются почками?
Так, мы не изучали этого. Мы, в наше исследование.
Выведение их. То есть, if you're talking about elimination, it's kidney or intestinal. It's not your work. It's like information about
information. It is inflammation of kidney.
Okay, why I ask this question? Because you use rosuvastatin and atorvastatin, but not why not other statins? Maybe pitavastatin or
other statins not used, but this no includes this research.
And also, could you tell us, please, what's your impact in this work? What is your impact in this work?
Okay, it is data collection, design research, statistic information, and
okay, thank you. And the last one, what will be the next step of this work? What do you plan to do in the future?
Next step in the write on dissertation on this team.
No. Perfect. Thank you so much, dear colleagues. If there are no questions, so we will have, if I'm not mistaken, it will be online. Online speech. Eleonora, thank you so much. Yeah. If with online speech, Alina Pyatskaya. The next speaker, she is from Moscow, and the theme of the work is evaluation of coagulation status in patients after COVID-19 using thrombodynaamic assay. Alina, you're welcome. 6 minutes.
Dear colleagues, good afternoon. My name is Alina Pyatskaya. I'm a PhD student and a junior researcher of the National Medical and Research Center for Therapy and Preventive Medicine in Moscow. I'm very glad to be here and to present the result of our work to you today. So the topic of my presentation is the evaluation of coagulation status in patients after COVID-19 using thrombodynaamics assay. I have no conflict of interest. As you know, hypercoagulation is one of the main characteristics of COVID-19 infection. Most of the studies that prove this fact were conducted during the acute phase of the COVID-19 infection. And nowadays, there are limited data about the persistent hypercoagulation in these patients. So the aim of our work was to study the coagulation status in patients after COVID-19 infection using thrombodynaamics assay. You see, thrombodynaamics is a validated, easy method that allows evaluating the coagulation status of the patients, measuring spatio-temporal parameters of the clot formation in vitro system. So the main thrombodynaamic parameters are the rates of clot formation, the size of the clot density, clot formation delay time, and the time of appearance of spontaneous clots. We included in our study adults who were hospitalized in our clinic with a history of confirmed COVID-19 infection, and of course patients who signed informed consent. We didn't include patients with diseases requiring long-term use of anticoagulants, like patients with atrial fibrillation or patients with mechanical heart valves. We didn't include patients with conditions associated with changes in parameters of the blood coagulation system, for example, patients with hemophilia. And also we didn't include patients with severe comorbidities. We defined coagulation status in our patients by changing in at least one of the thrombodynaamic parameters, as you can see on this slide. So we included in our study 41 patients with the mean age of 61 years. 40% of the patients were males. Patients had cardiovascular comorbidities. You see 5% of the patients had a history of stroke, 15% of the patients had a history of type 2 diabetes mellitus and myocardial infarctions. 85% of the patients suffered from hypertension. Approximately half of the patients take antiplatelet drugs. In most cases, it was aspirin. Using thrombodynaamics assay, we revealed that 76% of the patients had hypercoagulation status. Only 32% of the patients had normal coagulation status, and no one patient had hypercoagulation. The median of the period after COVID-19 infection was 6 months, and more than half of the patients had COVID-19 associated pneumonia. We found no differences in the thrombodynamics parameters and the history of COVID-19 pneumonia in our patients, as you can see on this slide. We found only mild correlation between the size of the clot and the period after COVID-19 infection, and no relationship between other thrombodynamic parameters and the period after COVID-19 was revealed. So in our study, the prevalence of hypercoagulation reached 76% among patients admitted to our hospital, even prolonged period of after COVID-19, regardless of the severity of the previous infection. So thank you all for your attention. If you have any questions, I'm pleased to answer them.
Colleagues.
Can I go?
Yeah, thank you. Yes.
Elena, excellent, really clear. Just wanted to know, obviously you have the presentations you found in 44 patients, which again can be deemed as a selective hospitalized patients, this percentage. But what is the overall meaning? Because other studies, long-term studies with a prolonged follow-ups of COVID patients have not shown that much incident cases of VTE now. So is this kind of a bias there going on, or because you do not have a control group? So how do you reconcile your findings with the findings from a bigger cohorts which are now available quite all over the world now?
Thank you for the question. Of course, one of the main limitations of our study is the small group of the patients, and now we continue recruitment, of course. Yes, as you can say, the data about the VT accidents in patients after COVID-19 is now controversial, and in some studies there are really small numbers of the patients with VT accidents, but in some studies, for example, studies with rivaroxaban, Michelle, there is really higher than the average rates of the VT cases. So we think that maybe some patients are underestimated for VT cases, and we hope, of course, in the future that the results of our study could help really to determine the candidates for long-term anticoagulations and really the definition if the patients really required in these anticoagulants.
Thank you.
Thank you for the question.
Thank you very much. Dear colleagues, maybe have another questions? Okay. Yeah.
I do have a question, actually. In the beginning of pandemic, actually, we have extreme, like almost 80% of patients we were treating with anticoagulation. And now, I think it's less than 5%, at least in here in Bronx. And I don't know how to explain this, but I don't know, maybe the virus is changing. Maybe we already have immunity in the community and the disease is not so severe. This study was done when exactly?
Yes, thank you very much for the question. Yes, it's really good question. So this study was conducted before the widespread of vaccination in Russia and before the changes in the virus's genotype. This study was conducted, then the anticoagulants in Russia was used very widespread. So I think even now, anticoagulants in Russia is widespread for these patients. So of course it depends on country and the protocols.
So it was in the beginning?
Yes, it's the beginning, yes.
Okay.
Thank you. Thank you, our colleagues, for your active participation in the discussion. So, Alina, and what is the future, directions of your work, or can you comment?
Yes, of course. Thank you for your question. So, as I have mentioned, we continue recruitment, and one of the main goal for this study is also to estimate the VTE accidents in our patients and compare the results of thromboddynamics parameters and the VTE accidents. Yes.
It's clear, I think, yes. So we can go. Thank you, Alina.
Thank you very much.
We can go to another one.
So, and the last speaker will be Pankova Ekaterina. Ekaterina from Chelyabinsk, and the theme of her work will be cardiometabolic risk factors in young people with liver stenosis. Ekaterina, are you with us?
Dear colleague, let me introduce my report.
Yeah, you can start. Thank you.
Ekaterina, you can start.
Okay. We have no conflict of interest. Epidemiological studies published over the last 50 years have shed light on the many risk factors that increase cardiovascular risk. It is now widely accepted that an altered lipid profile, including low protein cholesterol, as well as low high-density protein cholesterol, high blood pressure, smoking, and sedentary lifestyle all increase one's cardiovascular disease risk. Dear colleague, let me introduce my scientific report. Cardiometabolic risk factors in young people with liver steatosis. We have no conflict of interest. Epidemiological studies published over the last 50 years have shed light on the many risk factors that increase cardiovascular disease risk. It is now widely accepted that an altered lipid profile, including low density protein cholesterol, as well as low high density cholesterol, smoking, increase high blood pressure, and sedentary lifestyle all increase one's cardiovascular risk. Over the past 4 decades, non-alcoholic fatty liver disease has become the most common chronic liver disorder with a global prevalence of around 25% of adult population. NAFLD is a liver compound of a cluster conditions that are associated with metabolic dysfunction. NAFLD is a condition characterized by different hepatic abnormalities ranging from simple steatosis to serious, which with an increased risk of development of hepatocellular carcinoma. The disease spectrum of NAFLD extends beyond different stages of hepatic abnormalities and to include multi-organ involvement. Patients with non-alcoholic fatty liver disease have a different various comorbidities, which lead to increasing hospitalization and decreasing quality of life. Cardiac death is the most common cause of death in non-NASH and early ASH. Meta-analysis shows that patients with NAFLD have the risk of developing cardiovascular disease by 1.6 times. The bidirectional relationship between NAFLD and some metabolic syndrome feature, in addition to its characteristic proteogenic lipid profile, is one mechanism by which NAFLD may augment cardiovascular risk. In 2020, an international panel of experts proposed a new concept of metabolic dysfunction-associated fatty liver disease to highlight the contribution of metabolic risk factors to the development and progression of liver disease. The aim of our study was to evaluate body composition, the frequency of cardiometabolic risk factors in young individuals with without liver steatosis. Material and methods: a type of research case control study, study population young individuals at outpatient department in Chelyabinsk City Hospital in 2020-2021 years. Inclusion criteria were age 18-44 years, consent to participate. Exclusion criteria were endocrine disease, including diabetes mellitus, acute and chronic liver diseases, alcohol abuse, associated clinical conditions, including chronic kidney disease, mental illness, infections, constant intake of medication at the time of inclusion in the research, pregnancy and lactation. The patients were divided into two groups. Group 1, patient with liver steatosis, group 2, patient without liver steatosis. Material and methods for clinical examination and review of medical documentation, biochemical analysis, serum adipokines, abdominal ultrasound, body composition, medical statistical software package was used. In group 1 had higher values of diastolic blood pressure, body mass index, and waist to hip ratio compared to group 2. Higher amounts of total and visceral fat were observed in group 1 compared to group 2. Higher frequency of hyperglycemia, overweight, obesity, and hyperuricemia were found in group 1 compared to group 2. Individuals with liver steatosis have higher values of index HOMA, plasminogen activate inhibitor type 1, and lower resisting concentration compared to group 2. Conclusions: in young individuals with liver steatosis were revealed high levels of diastolic blood pressure along with higher values of body mass index and waist to hip ratio compared to group 2. The most frequent cardiometabolic risk factors among young individuals with liver steatosis were overweight, obesity, hyperuricemia, and prediabetes. Higher amounts of total and visceral fat were observed in young individuals with liver steatosis compared to group 2. In young individuals with liver steatosis, changes in carbohydrate and lipid metabolism were accompanied by insulin resistance and adipokine imbalance. Thank you for your attention.
Ekaterina, can you hear me?
Yes.
So the question is it your PhD work or is it work after your PhD?
In future, maybe, no. What is the question?
Okay. What is your impact in this work? You're doing this work during your PhD?
Patient enrollment and statistical analysis with my scientific advisor and presentation of my results in the future.
Okay, thank you so much, Ekaterina. Dear colleagues, do you have any questions for Ekaterina? Okay, thank you so much. So we want to finalize the Young Investigator Award, and I would like to ask our colleagues to maybe to make some conclusion, to give some advices for young investigators, if it's possible. Dear Kristina, would you like to make a conclusion or some your impression about this Young Investigator Award?
I mean, thank you so much for all the reports. I think it's a lot of novelty in most of them. You know, some of the reports are very good, and a lot this you know, like these are all very like small study, and the relevance of the although the studies are important and you have a signal maybe in these small studies, but for the to reach the significant, the studies needs to be larger in majority of these presentations, and I think that these presentations were very good. Thank you very much.
Okay, thank you so much, Kristina. And also, I would like to give a word for Ajay Gupta. Would you like to make some conclusion, also to give some advices for young investigator, Ajay?
Thank you, Irina. This is an excellent session. I really commend all the speakers. They have done a hard work and presented these studies, which obviously Kristina said may potentially make an impact. Obviously, it's a start, a small beginning. But I'm very impressed with these findings and the way they have presented. So I will only say that they need to continue with their work. These are the first steps. What they need to do, what was very apparent is that they have put in a lot of hard work. But what they need to start thinking about is why and how these studies make an impact. So important aspect is the research integrity. And your findings, whether there's a biases coming on, how can, is there a confounders there? Because most of the studies, there were a bias and a confounders, and it will make others not believe your results. So it's very important when you start your studies, you need to think about the study design. So that is one most important aspect. And second is the hypothesis. The hypothesis needs to be a novel. Some of those work has been iterative, has been done already, and you are just presenting that. That's a good experience. But if you want to make an impact, you need to think about where are the gaps, and then make your studies design according to that gap.
Thank you very much for this, very important notes for our young investigators. Thank you. So, Dr. Christian Schneider, are you here with us? Please. No. Okay. So, Dr. Milica Vukchevich.
First of all, I would like to thank all of you for inviting me to be part of this amazing forum, like last year. And I would join to AJA as an expert for research, and I would confirm all he said and all the suggestions he gave to young investigators. On the other hand, when talking about the field of cardiology, I'm happy that we talked a lot about heart failure patients, and also that we had one presentation and report in the field of heart transplant. And unfortunately, in the future, after COVID, I think we will face even more patients with heart failure, and that the early detection of heart failure is very important. So maybe I would focus on this in the future, and also about focus on recognition of maybe heart transplant candidates on time in the future. But first of all, in early detection of heart failure. So I would like to thank all investigators for excellent presentations, and I wish you luck, everyone. Of course, there is a limited number of awards, but we will do our best to try to choose the best ones. Yeah.
Thank you very much. Thank you all. So, Irina, we can conclude.
Dear colleagues, dear judges and co-chairs of this session, I'm glad to present the information that this investigator award was successful, and it's very
I hope that in future we will see each other not only online, and we hope that now it's like a science without borders, and because of which we are very thankful for you that our abroad colleagues were with us today. And dear Young Investigator, I would like to thank all of you. You are the best of the best, and you should know about this. And all results you will get tomorrow at the end of the Forum of Young Cardiologists at 5:30, if I'm not mistaken. And dear colleagues, all results about your opinion about the 3 best young investigator you should send to me by phone or by mail. And thank all of you. And also I would like to thank my co-chair who was with me here. It's Kudzoyeva Залina, and give her the last words of this session.
Thank you very much, Irina. It was really very interesting. Thank you for the invitation to moderate this session. It was really very important to, to present for young investigators their works, because it is the beginning of their, I hope, very huge work in scientific field of cardiology and cardiovascular surgery. So I also think it was very successful. And again, thank you very much for our abroad judges. Thank you. Thank you all. We can conclude. Thank you.
Thank you. I hope to see each other next time, next year, maybe. Thank you for your participation with us, for spending your time to Young Investigator Award, dear colleagues. So we will mail each other. Goodbye.
Дорогие коллеги, каждый, кто